Imagine this. You've just administered a standard local anesthetic.
Right, just for some routine conservation work.
Exactly.
Yeah.
And you turn your back, just to adjust your tray, and 20 minutes pass.
A completely normal time frame.
Yeah, but when you turn back around, your 55-year-old patient is visibly agitated. I mean, he's clutching his chest, he's gasping for breath.
Oh, wow, yeah. That's terrifying.
Right, and your dental nurse leans over, asks if he's okay, and suddenly he just slumps over in the chair, unresponsive.
The absolute worst-case scenario.
Yeah, you are definitely no longer doing a filling, the quiet hum of your clinic is gone, and you are literally fighting the clock to save a life.
It's the ultimate high-stakes clinical pivot. And in that exact fraction of a second, cognitive paralysis is your absolute worst enemy.
For sure. So, welcome to the deep dive. Today, we have a really vital mission. We are cracking open the pages of Odell's clinical problem-solving in dentistry, and we're zeroing in on a scenario that every single practitioner dreads, but obviously must be prepared for.
Case 13, right? Sudden collapse.
That's the one. And before we get into the physiological breakdown, you should check out our pinned comment and the poll on Spotify.
Yeah, we really want to know what your immediate initial differential diagnosis is for this specific scenario. Like, what jumps into your head first?
Exactly. Lock in your answer before we reveal the clinical reasoning here. So whether you are an ADC candidate prepping for your OSCE exams, or, an Australian oral health therapist, a dental student, anywhere in the world, really.
Or even just an experienced practitioner doing a mental audit of your emergency protocols.
Right. This deep dive is for you. We are going to meticulously break down the diagnostic reasoning and the absolute physiological mechanisms of managing an unresponsive patient.
And just a quick note for clarity before we jump in. Our discussion today is purely educational. We're just analyzing the clinical frameworks from Odell's text.
Yeah, definitely not a commercial endorsement or anything like that.
Exactly. So let's look at the hard evidence here. We have a 55-year-old male who notoriously dislikes injections.
Which is pretty common.
Very common. And he has an established medical history. He's an insulin-dependent diabetic, well-controlled, though.
Okay, good to know.
And hypertensive. He's currently taking 20 milligrams of enalapril daily. Plus, he's overweight, smokes 20 cigarettes a day, and reports a weekly alcohol intake of about 30 units.
Okay, so let's unpack this. If you're sitting there, taking your OSCEs, it's incredibly easy to confidently recite the textbook response.
Oh, absolutely. In a quiet exam room, sure.
Right. But in your actual clinic, when that patient suddenly turns gray and stops responding, fighting the immediate human instinct to dial emergency services takes immense discipline.
It really does.
Because my gut reaction would still be to just scream for someone to call an ambulance instantly. Do we actually delay that call?
Well, according to Odell's clinical framework, yes. You absolutely delay that call for just a moment.
Wait, really?
Yeah. Your first immediate action is to confirm unconsciousness. You physically shake their shoulders and shout to rouse them.
Okay, so just checking if they're actually out.
Right. And if there's zero response, step 2 is shouting for local help. That means your practice team, the nurse, the receptionist, the hygienist next door.
I have to admit, that still feels deeply counterintuitive to me. Why are we keeping this entirely in-house when a man is literally unconscious in the chair?
Because you have to play the clinical odds while rapidly assessing the physiology. The overwhelming statistical probability for a sudden loss of consciousness in the dental setting is a simple vasovagal attack.
A faint.
Exactly, a faint. Summoning a fully equipped ALS ambulance for a transient vasovagal episode is, frankly, a massive misallocation of emergency resources.
Oh, I see.
Shouting for local help gets you the extra hands necessary to manage the patient, retrieve the emergency drug box, and, prepare to escalate to emergency services if the diagnostic picture demands it.
Which brings us to the actual diagnostic picture. We need to figure out the underlying mechanism of this collapse.
Right. We have to play detective.
Yeah, let's look at this like sorting through a cascading system failure in a complex machine. We have the catastrophic output, the collapse, and we have to cross-reference his symptoms against his medical history to isolate the failing component.
I like that analogy. And Odell outlines 4 primary suspects for this specific environment. You've got vasovagal attack, hypoglycaemia, steroid crisis, and cardiac arrest.
Okay, let's interrogate the vasovagal response first, since you mentioned it's the most common.
Sure, let's trace the physiology. A vasovagal faint is typically triggered by anxiety, pain, or the sight of blood. And we know this patient strongly dislikes injections.
Right, he was definitely anxious.
Mechanically, you get a sudden withdrawal of sympathetic tone and a massive surge in parasympathetic activity via the vagus nerve.
So the system essentially short circuits.
Essentially, yes. The vagal surge causes profound bradycardia, and the sympathetic withdrawal causes extensive vasodilation, particularly in the splanchnic and lower limb vascular beds.
Meaning the blood just drops down to his legs.
Exactly. Blood pools in the periphery. Venous return to the heart plummets, and consequently cerebral perfusion drops below the critical threshold required to maintain consciousness.
And clinically, that presents with the classic premonitory signs, right? The patient feels lightheaded, the skin becomes acutely pallid and diaphoretic.
Sweaty and pale, yeah.
And usually, if you just adjust the physical gradient, like laying them supine with a maximum 10-degree head-down tilt gravity, restores that venous return, and they recover pretty rapidly.
Exactly. But if we connect this to the bigger picture of our specific case, the evidence fundamentally contradicts a vasovagal diagnosis.
Oh, because of the pain?
Yes. This patient experienced crushing chest pain and acute breathlessness 20 minutes after the trigger event. A parasympathetic vagal surge simply does not manifest with radiating crushing chest pain.
Right, the pump slowing down wouldn't cause that kind of localized agony, so the vasovagal theory is officially out. Let's move to the second potential system failure, hypoglycaemia. Now, this patient is an insulin-dependent diabetic, so the baseline risk is already actively sitting in our chair.
It's a very strong hypothesis. When a diabetic patient is under stress, or their caloric intake is mismatched with their insulin dosage, blood glucose can rapidly fall below the level required for neuronal function.
Because the brain literally runs on sugar.
Exactly. The brain has an obligate need for glucose.
Right.
When it is deprived, the body initiates a massive counter-regulatory response.
And here's where it gets really interesting, because the clinical presentation of hypoglycemia isn't actually just the brain shutting down, right?
Right.
It's the body's desperate, almost violent attempt to keep the brain online.
Spot on. What's fascinating here is that the symptoms we observe, the profound diaphoresis, the pronounced tachycardia, the tremors, they're driven entirely by catecholamine release.
Adrenaline, basically.
Yeah, the sympathetic nervous system dumps adrenaline into the bloodstream to force the liver into glycogenolysis. It's desperately trying to convert stored glycogen back into circulating glucose.
That explains the sweating and the racing heart. And mentally, before the total collapse, they become incredibly confused or even aggressive because the cerebral cortex is starving.
Right, and Odell notes that if they are conscious, you administer oral glucose. But if they've already crossed into unconsciousness, you administer intramuscular glucagon to force that liver conversion artificially.
Okay, but once again, we hit a diagnostic wall with the actual case presentation.
You do.
Because while the sweating and the collapse align perfectly with severe hypoglycemia, the acute preceding chest pain just doesn't.
No, it doesn't. The sympathetic drive of a hypoglycemic episode can definitely cause palpitations, but not the crushing, localized pain our patient experienced.
So we strike hypoglycemia from the list. What about a steroid crisis?
Well, a steroid crisis, or acute adrenal insufficiency, happens when the adrenal glands cannot mount the necessary cortisol response to physiological stress.
And cortisol is what keeps the blood pressure up during a crisis, right?
Exactly. Cortisol is required to maintain vascular tone. Without it, the patient suffers catastrophic hypotension and just collapses.
But this guy isn't on steroids.
Right. This is exclusively a risk for patients with suppressed adrenal function. Typically those currently on or recently withdrawn from long-term systemic corticosteroid therapy.
Looking at his medical history, he's taking enalapril and insulin, no systemic steroids.
Not at all.
So the adrenal axis should be totally intact. That system failure is definitively ruled out, which leaves us with a terrifying reality. Suspect 4.
Cardiac arrest.
So what does this actually mean for the patient physically sitting in front of us? I mean, how did we get from a routine filling to a massive cardiac event?
If we look at the cascade, the symptom of sudden crushing chest pain, particularly pain the radius to the neck or the left arm, is the absolute hallmark presentation of myocardial ischemia.
A heart attack.
A myocardial infarction, yeah. He has a textbook profile for advanced atheromatous arterial disease. He's diabetic, which accelerates vascular damage. He's hypertensive, creating shear stress on the endothelium.
And he's a heavy smoker.
Exactly, which promotes plaque formation and thrombosis.
So it's the perfect storm for a coronary occlusion. An atheromatous plaque ruptures, a thrombus forms, and suddenly the myocardium is just starved of oxygen.
Yes.
The resulting ischemia triggers those visceral afferent pain fibers, giving us the crushing chest pain. But wait, does a myocardial infarction automatically equal a cardiac arrest?
That is a critical distinction.
Does the electrical system just short out the second the tissue gets starved?
No, they are not synonymous. A patient can have a massive myocardial infarction and remain conscious, with the heart still generating a viable, albeit compromised, cardiac output.
Okay, so when does it become an actual arrest?
Cardiac arrest occurs when that ischemic damage disrupts the electrical conducting system, triggering ventricular fibrillation, or when the infarct is so massive that the pump mechanically fails altogether.
Wow.
In the dental setting, cardiac arrest can also be secondary to profound hypoxia from airway obstruction.
Yeah.
But given the sequence here, acute chest pain followed immediately by a total loss of consciousness, we must assume the electrical or mechanical system has failed entirely.
Right. We must assume cardiac arrest until proven otherwise. An anchoring bias here could be lethal. If you assume it's just a faint because faints are common, the patient dies.
Exactly.
So how do we definitively prove cardiac arrest right there in the chair without, an ECG monitor?
The clinical criteria are absolute and require immediate assessment. For diagnosis of cardiac arrest, the patient must be unresponsive and they must have absent or distinctly abnormal breathing, like those agonal gasps.
Right.
You simultaneously assess for a central pulse. Odell specifies palpating the carotid artery in the neck.
Oh, because peripheral pulses, like the radial artery, disappear the moment systolic blood pressure drops below about 80 millimeters of mercury.
Correct. But the carotid remains palpable much longer. So if the carotid is absent, the pump has officially stopped.
And in Odell's scenario, the patient is completely unresponsive, he is rapidly becoming cyanosed, turning blue, and there is no carotid pulse.
The diagnosis is confirmed, the system has failed, and now the timeline shifts from minutes to mere seconds.
It's go time.
We immediately transition into the basic life support protocol, dictated by the Resuscitation Council guidelines. This is the non-negotiable minimum standard of competency for anyone operating in a dental clinic.
Okay, let's step out of the textbook and into the room. The patient is cyanosed. My adrenaline is absolutely spiking. My hands are shaking. Do I just dive straight over the chair and start crushing the sternum to force blood to the brain?
If you do that, you're setting yourself up for catastrophic failure.
Really?
Yes. Step one is always checking for danger. You have to assess the environment. Are there sharp instruments? Is the dental chair positioned safely? You cannot deliver effective resuscitation if the environment compromises you or your team.
Okay, makes sense. So the area is clear. We've established unresponsiveness. We shouted for the local team. What is the very first physical intervention?
The airway. You must open the airway using a head tilt and chin lift, or a jaw thrust if cervical trauma is suspected, though that's pretty unlikely in a dental chair collapse.
Right.
What's fascinating here is that practitioners often rush past this step, yet airway obstruction is the single most common cause of BLS failure.
Because if the airway is blocked, any compressions or ventilations you attempt are completely useless. You're just forcing air against a closed physiological door.
Exactly.
But what exactly is blocking it?
It's the patient's own anatomy. In a state of profound unconsciousness, the musculature of the pharynx completely loses its tone.
Oh, the tongue.
Yes. The tongue, which is a massive muscular organ, simply obeys gravity. It falls backward and physically occludes the oropharynx.
So by physically tilting the head back and lifting the point of the chin, you pull the supporting structures of the anterior neck, lifting the tongue right off the posterior pharyngeal wall.
You're mechanically repositioning the anatomy to clear the pipe.
Got it. And Odell also mentions using finger scoops to clear the oral cavity of any visible debris or vomit, right?
He does, yes.
Which brings up a highly specific but honestly critical question. What if the patient is wearing dentures? In the panic of clearing the airway, do I rip the dentures out to ensure the mouth is completely clear?
Well, Odell is very explicit on this point. You only remove dentures if they are visibly loose or broken.
Wait, seriously? You leave a removable prosthetic in the mouth of a patient in cardiac arrest?
Absolutely. Think about the mechanics of expired air ventilation. To deliver effective rescue breaths, you need a perfect airtight seal around the patient's mouth.
Oh, I see where this is going.
If a patient is edentulous and you remove their well-fitting dentures, the facial tissues and the lips completely collapse inward. It becomes incredibly difficult to establish that seal, and the air you blow will just leak out around the cheeks.
That makes total sense. The dentures provide the necessary structural architecture to maintain facial integrity for ventilation.
Exactly.
That is a phenomenal piece of anatomical reasoning that you really only encounter in specialized dental training. Okay, so the airway is clear, the architecture is supported. Now what?
You assess breathing, you maintain that airway, and you look, listen, and feel.
Yeah.
You watch for chest rise, listen for breath sounds, and feel for air movement against your cheek.
Okay.
But you must restrict this assessment to a strict maximum of 10 seconds. Do not waste time waiting for a breath that isn't coming.
And if there is no normal breathing, like if they are completely apneic or just exhibiting those infrequent, noisy agonal gasps?
That is the exact trigger point. Now you call emergency services. You tell your local team member to immediately dial 999 or your local equivalent, state that you have a cardiac arrest, and retrieve the emergency equipment, including the automated external defibrillator, the AED.
The cavalry is finally on the way. But we obviously can't just wait. We have to become the life support system.
Immediately commence chest compressions. You place the heel of your hand over the lower half of the sternum and compress the chest at a depth of 5 to 6 centimeters at a rate of 100 to 120 compressions per minute.
We are essentially utilizing the thoracic pump mechanism. By aggressively compressing the sternum against the spine, we are physically squeezing the heart and increasing intrathoracic pressure to force a forward gradient of blood flow to the cerebral cortex.
Precisely. You are manually maintaining minimum cerebral perfusion, and after 30 compressions, you deliver 2 ventilations.
30 to 2.
Yes. You pinch the nose, maintain the head tilt, and blow steadily until you see visible chest rise. Then, your hands go immediately back to the sternum. 30 compressions, 2 ventilations, over and over.
Because even though we are pumping the blood, that blood only has a residual amount of oxygen left in it from the moment they collapsed. If we don't physically force fresh oxygen into the alveolar space, we are just circulating deoxygenated blood to a starving brain.
Exactly right. You maintain that strict 30-to-2 ratio until the AED arrives and is attached, until advanced emergency medical personnel take over, or until the patient demonstrates clear signs of life, like purposeful movement or normal breathing.
Okay, let's be a breath ourselves and look at the sheer reality of this protocol. We've executed Odell's framework flawlessly. We secured the airway, maintained the oral seal, initiated perfect compression.
Everything by the book.
Yeah, but what are the actual stakes here? Does textbook execution guarantee survival?
The reality is incredibly sobering, and honestly, Odell doesn't shy away from it. The primary objective of BLS is not necessarily to restart the heart. That usually requires the electrical shock of a defibrillator or advanced pharmacological interventions.
Right.
The primary aim of BLS is entirely about protecting the brain.
Because neuronal tissue is just incredibly fragile when deprived of oxygen.
Yes. In a normothermic patient, irreversible hypoxic brain damage begins to develop within just 3 to 4 minutes of cardiac arrest.
Wow. 3 minutes.
BLS artificially delays the rate of that cellular death. It extends the window of viability, buying time for advanced life support, or ALS, to arrive.
And if you do everything perfectly, and the ambulance arrives in record time.
Even with prompt, high-quality BLS from the dental team and rapid intervention from ALS paramedics, the mortality rate for out-of-hospital cardiac arrest remains greater than 50%.
God, more than half of these patients will still not survive.
That's right.
That is a brutally heavy statistic for any healthcare provider to carry.
It is. But you have to look at the alternative. If BLS is delayed, if the dental team freezes in panic, if they misdiagnose it as a faint, and just wait for the patient to wake up, wasting those critical first few minutes, the chance of survival absolutely plummets to less than 2%.
Less than 2%. That is literally the difference between life and certain death, dictated entirely by the immediate competence of the people in that room.
Which is exactly why Odell stresses that intellectual knowledge is insufficient. You cannot learn to manage a cardiac arrest purely by reading a clinical guide or listening to an analysis.
You have to practice.
Regular, highly realistic, simulated emergency drills with the entire dental practice team are an absolute necessity. When a patient collapses, the adrenal stress on the clinician often causes higher-order cognitive processing to shut down.
You just go blank.
Exactly. You must have drilled the physical protocol so deeply that muscle memory seamlessly takes over when fear paralyzes the mind.
It fundamentally changes how you view a dental practice. I mean, it isn't just an environment for managing enamel, dentin, and periodontium.
Not at all.
Because of the inherent physiological stress of dental procedures, the pharmacological impact of local anesthetics, and the incredibly complex, often fragile cardiovascular profiles that patients bring into the chair every single day, that room can instantly transition into a frontline trauma bay. Dental professionals are undeniably first responders.
It's a profound and unyielding responsibility.
It really leaves you with a fascinating thought to chew on. I mean, as dental technology allows us to perform increasingly complex multi-hour procedures on a rapidly aging demographic with advanced systemic comorbidities, the likelihood of these acute medical crises in the chair is only going to rise.
That's statistically inevitable.
It makes you wonder, will advanced life support certification, ALS, rather than just BLS, eventually transition from being a specialized skill to the absolute mandatory baseline standard for legally operating a dental clinic in the future?
You know, that is a shift in the educational paradigm we may well see in our lifetimes.
It's a completely vital conversation. For more dental examination prep tips and clinical deep dives, please subscribe to our Spotify and YouTube channel and share this deep dive. See you next time.